I'm Thomas Baldrick at the 2014 ASH Conference. This is Dr. Elias Jabbour from the MD Anderson Cancer Center. Thanks for coming back and seeing us.
Absolutely, my pleasure. Thank you for having me.
Let's talk about this report you have on behalf of the MDS Clinic Research Consortium. What's this about?
Well, we decided to go over patients with MDS. You know, for this patient, the treatment is the curative approach is transplantation. Or a lot of patients can't make it because of either they are very old or they have problems, comorbidities, or no donor. But when you look at the survival curve, we did identify or we have a plateau or a tail. Small subset of patients, like maybe 15% or less, can plateau, mean they can benefit from therapy and may not need a transplantation. The idea of this analysis, and this is preliminary, that to identify patients in whom survival seems to be steady and no further decrease. And the cutoff was found to be around 34 months. Means somebody on therapy who make it and maintain the response till 3 years and beyond seem to be stable and not anymore progressing and dying from the disease. That is new because the treatment available, none of them is curative and still transplant. When we identify these factors at the baseline, that help us guiding our patients, which one should go for transplantation, which one should remain on therapy, or at least in patients in whom there's no donors, we can identify a group where treatment can be effective and can lead to a durable response.
What do you think is most significant about this?
Well, it's really important findings because it's important to identify a group of patients in whom, for example, let's say you have a patient in whom he doesn't have a full donor, he doesn't have a full match, okay? And now with genome sequencing, we can identify a group of patients in whom maybe the disease is not as aggressive. And instead of offering transplant to everybody, where we know that it's not a walk in the park, where certain subset of patients may die from transplant, the disease may come back. So we can find an alternative for these patients, and maybe they don't have an aggressive disease enough to require transplantation, and where the survival can be maintained and the disease well controlled.
Now, what work might you do to build upon this report?
Well, this is done with essentially MD Anderson, but it's a work of the the North American MDS Consortium. So we try to gather the data from different centers, among them Moffitt, Cleveland Clinic, Hopkins, Dana-Farber, and Cornell, New York, so they can have a large data where we can validate the findings already reported, and hopefully with that, with bigger data, we can have strong argument eventually to advise our community doctors, our colleagues, or patients in whom what alternative to be offered. That is one. Second, with the advance of technology and genome sequencing, we have a better understanding of the disease rather than just relying on clinical parameters. With implementation of clinical, biological, and molecular markers, we can better identify a group of patients in whom eventually cure can be offered and transplant may not be needed.
Very good. Thank you, Doctor. Appreciate
Absolutely,
your time.
my pleasure. Thank you.